Hi, everyone. Good morning. We will get started in just a moment, and we're glad you're joining us today. Good morning, everyone, and thank you so much for being here today. I'm honored to welcome you to the official launch of the resources developed through the Advancing a Sustainable Hospital at Home Ecosystem at Scale initiative, the inaugural project of the Connected Health Collaborative community. We kicked off this project last fall, and since then, I've had the privilege of working alongside brilliant, passionate leaders from across the healthcare ecosystem, including providers, health plans, policymakers, technologists, and patient advocates. These partners didn't just bring their expertise, they asked the hard, honest questions needed to help build a truly sustainable hospital at home ecosystem. And they showed up with a shared commitment to making this model a safe, effective, and lasting option for patients. Hospital at home has come a long way from pandemic era necessity to a powerful opportunity to reimagine how care is delivered. Today's launch is about more than just new resources. It's about practical, scalable solutions grounded in real world evidence. These tools are designed to help us move beyond temporary pilots and fragmented policies toward a model of care that is sustainable, effective, and here to stay. Today, you'll hear from a fantastic panel of experts who helped shape the work and get a preview of the resources that officially launched today. But before we dive in, I want to extend my gratitude to everyone who made this possible, including the Consumer Technology Association for co-hosting this community, to our impact sponsor, UMass Chan Medical School's program in digital medicine, and to every single project partner who generously shared their time, expertise, and perspective with our team. With that, I'm excited to introduce my colleague, Jake Sintra, who will walk us through a brief overview of the resources launching today. Thank you again for being here. And Jake, stage is yours.
Thank you so much, Abby. What an honor and a privilege to have the opportunity to share this first look with everyone today at a web preview of the blueprint for scaling hospital at home. And so we'll start on the homepage and then we'll go through the 4 sections of the blueprint together live on the Dime site. And when you first encounter the blueprint for scaling hospital at home, you'll have an opportunity to read some intro text, but also watch an animation where you can get that detail about those 4 sections of the blueprint and the 5 key stakeholder groups we designed these resources to support. And as you scroll down the homepage, you'll be able to navigate the blueprint and look into those 4 sections, which are the patient journey map in section 1, the technical and operational considerations in section 2, the program evaluation and reimbursement pathways in section 3, and the implementation pillars or the pillars of successful implementation in section 4. And each of these sections is described below the graphic, and you can dive right in from here on the homepage, or at any point as you scroll, there's a navigation bar that follows you down the project page. Before we dig into section 1 in the patient journey map, let's just talk a little bit about who we designed these resources for. And so when in development with the project team, we were thinking about health systems and providers, health plans and payers, regulators and policymakers, digital health technology developers, and patients and care partners. And so before digging in, you can actually just get a little bit of insight, 1 to 2 sentences on how to view these resources, this blueprint through your specific lens as a user. And so I would encourage you to check that out on the homepage. Of course, we love to highlight our impact sponsor and project partners, who without them, none of this would be possible. You can also find quotes from our partners about seeing these resources in action and how we are positioned to shape the field. And there's also some more information on upcoming Dime projects as well. But without further ado, let's dig into the first section of the blueprint for scaling hospital at home. And so this first section is really a narrative section called the patient journey map. And we identified the need for a unique source of truth to align all stakeholder groups on what is the patient and their care partner actually experiencing as they move through the hospital at home care journey. And so you can interact with all 5 phases of the patient journey map via the graphic. starting with identification, referral, consult, and assessment. Phase 2 is consent and planning, the actions before the patient transitions home. Phase 3, preparation and initiation, so starting care at home. Phase 4, care delivery and monitoring, that active clinical management phase. And then the fifth phase, which is discharge planning and care transition, so that primary care provider and community next step. And you can dig into each of the phases from here, or you can just scroll down section 1 and you'll encounter each phase by name, that narrative that I mentioned, where it's really about what is the patient and what is the care partner experiencing as they move through hospital at home. And you can expand each of these accordions below the phases to find the actions that are taken by all of the stakeholders that deliver that hospital at home care or support that care journey. And that is true for all 5 phases. You can scroll linearly or always go back to the journey map to learn more. And so that's section 1, but it's really closely related to section 2. And section 2 of the blueprint is the technical and operational considerations. And this is where we dig deeper to support that narrative, that patient journey, by digging into the robust technical infrastructure and the well-designed operational frameworks necessary and how those elements really must work together to deliver that acute level care safely and reliably at home. And if you're coming from section 1, you may want to map the technical and operational considerations directly to those phases of the patient journey so you can dig into that prioritized information for learning more about each phase. Or you can scroll through how we've organized it into the technical and the operational pieces. And each consideration has an accordion where you can expand, for example, building your core technology stack to learn more about deploying remote monitoring tools, implementing fit-for-purpose telehealth platforms, care coordination, medication management, etc. And what I'd really love to point out about this section is how it's intended to act not only as that deeper level of information, but also as a routing document so that you can be linked directly in the text to resources, references, and standards from the FDA, from CTA, from AWS, from Medically Home, and more, so that you can learn more and get to the level of detail necessary to confidently build and scale your hospital at home program. And so again, this is both technical and operational considerations that support that patient journey. Sections 1 and Section 2 also have this chatbot feature. So just want to point out that you can interact with the chatbot if you just want to introduce yourself and get some sample prompts, or if you want to ask questions to help you navigate or dig deeper into the material in these sections. So sections 1 and 2 have that additional feature to explore. Next, we're going to talk about Section 3 of the blueprint, which is program evaluation and reimbursement pathways. And this section really gets into demonstrating the value and impact of hospital at home. And so we begin by introducing why measurement matters. And that's because we need to be tracking program performance, demonstrating return on investment, comparing hospital at home to the traditional cost of care, driving payer adoption, and promoting value-based care integration. And when we're thinking about measurement, we identify who is the primary audience interested in measuring these things like value-based care or tracking program performance. What key business questions can we answer through measurement of these outcomes? And then what are the categories of those measures that support answering those questions and tracking that performance or demonstrating that ROI? And so you can either navigate to those categories of measures directly from here, or as you scroll, the next piece of section 3 is the key measures for evaluating the value and impact of hospital at home. And so not only is this important for everything we just discussed with tracking performance, demonstrating ROI, but for Medicare credentialed hospitals, submitting monitoring data for specific reporting measures is actually required for the CMS waiver pathway. And so we dig into that and link out here. But we also have just outlined a broad set of measures for each category. And so those categories include clinical quality and safety outcomes, access, equity, and experience, cost and resource utilization, and operational performance and efficiency. And again, within each of these, when you expand the accordion, you'll encounter a table that digs into that list of measures, a description of that measure in the context of hospital at home, and insights from the ecosystem and the literature. And here we can lean on CMS data, this robust set and report that came out of the Acute Hospital Care at Home initiative. We can look at international evidence as well through Cochrane reviews, and we can look at more evidence from the ecosystem. It's important to interpret these insights with nuance because there's different language that is associated with the waiver pathway versus non-waiver hospital at home programs. There are different conditions and levels of acuity of patients experiencing hospital at home. And there's just a difference in how outcome measures are defined and tracked in the literature. So using these insights, but developing your core set of measures for tracking program performance, demonstrating ROI, and comparing costs with that nuanced insight. And this ties directly into the final component of the third section, which is pathways to sustainable reimbursement. And so when we're thinking about all of this measurement, we also want to be thinking about what are the established models of payment for hospital at home programs, but also what are the emerging models and opportunities. And so we dig into for each payer type, as well as for value-based care contracting more generally, those payment approaches. And so we've got tables for CMS and Medicare programs, Medicare Advantage opportunities, state-specific Medicaid approaches, commercial and employer strategies, and value-based care contracting, as I mentioned. So the CMS and Medicare program table has a row for that waiver program payment approach. And all of the tables will also dig into how these payment approaches apply to hospital at home specifically, what actions need to be taken in order to align with this payment approach, and what financial considerations should be top of mind when considering this payment approach for your program. And when we get to the value-based care contracting table, there's an additional column for the typical payers who may be aligned for these type of bundled payments or contracts. And so again, when we think about measuring to track performance, to demonstrate ROI, to compare costs, we're also thinking about the established and the emerging models of payment that will build a strong foundation for the future of your hospital at home program. We've got one more section of the blueprint for scaling hospital at home, and that is the pillars of successful implementation section. And this section is really about best practices for overcoming implementation barriers and what does good look like in the ecosystem. And so with our team, we were able to identify 5 pillars. They are patient safety and experience, leadership engagement and stakeholder training, robust technical and operational infrastructure, strategic alignment, scale, and sustainability, and full integration into the care delivery model. And when you interact with each one of these cards, you'll be brought to the pillar, or as always, you can scroll linearly down and you'll encounter the name of the pillar, this best practice narrative about why this is what good looks like. We detail how each pillar aligns the hospital at home stakeholders that these resources were designed to support and who are involved in hospital at home. And we have out to the right either a testimonial, a case example, or that real world insight to share that shining spotlight of what good looks like. And we're able to highlight our partners here, which has been an absolute pleasure. Where you may have seen these throughout the resources, but you can also dig in a little bit more to pro tips where they're relevant, where there's additional levels of information we want to share, such as what an effective cross-functional team might look like in this second pillar for leadership engagement. And last but not least, we always refer back to other sections of the blueprint, specifically so that as you go through and as you see what good looks like, and as you start to learn more about what it's going to take to build and scale your program, you can stay within these resources and get that level of detail you need to confidently move forward. And so, again, there's 4 sections of the blueprint. Just an absolutely incredible experience developing these action-packed resources, and can't wait to see the impact we'll have on the field together. So thank you for the opportunity to share. And with that, I have the pleasure of introducing our next speaker, the CEO of the Digital Medicine Society, Jennifer Goldsack, for her remarks.
Jake, thank you so much. And congratulations, not just to you and the Dime team for this exceptional work, but also our tremendous partners who came to the table and were determined to join us and stand shoulder to shoulder in creating resources that prove out that hospital at home is no longer an experiment. It is a critical part of modern healthcare, and that we wanted to codify the best practices, the implementation guides, the key considerations that allow us to go beyond the 350 hospitals that already participate in delivering hospital at home, to making this a care pathway, a care modality that is available to every single patient who can benefit from receiving high acuity care in their home, where it is safe and where that is what the patient wants in order to improve their own experience and their own outcomes. And it's exciting to reflect on these resources in this moment, because the data is clear. The demand for this kind of service for the patients that our entire industry exists to care for is real. And we took seriously as a team, as a collective, our responsibility for delivering the resources to support durable systems to deliver at scale. And again, to every single patient who can benefit. And these sorts of resources, the patient journey map, the implementation pillars, the technical operation considerations, are so powerful because they start with the patient at the center. And I just want to applaud the project team again for taking this very patient-centered approach and in codifying all of this, creating the blueprint for expanding the reach, the access, not just the promise, but the proven success of hospital at home. I think the reason I was so excited by this work and the reason that I'm so bullish about the change it will make is because we are at a crossroads when it comes to hospital at home. We need to get this right. The current federal waiver is set to expire in September of this year. And without decisive action, and actually beyond decisive action, right? Without being able to demonstrate that this is a care pathway that is feasible, scalable, and embraces everything the new administration is looking at in terms of improving access and really leaning heavily into fit for purpose technology. Unless we do that right, we are going to run into problems, but I'm optimistic. I'm optimistic because this group, and again, kudos to the project team and thank you all of you on the line for joining, is refusing to allow innovation to retreat because the infrastructure, right? Because the blueprint didn't keep up. We are here and we have in fact launched today those resources that are going to keep us driving in the right direction as we drive towards a permanence in this critically important way of caring for people in the digital era and where patient unmet need is higher than ever. And I want to keep these brief, although I'm not sure I've done a terribly good job of that so far. I want to keep these remarks brief so we can hear from our exceptional panel. But, you know, beyond the practical tools that we've created today at Dime and in partnership with leaders in the field, we see, you know, challenges, we see obstacles as opportunities. I think we've proven that out with the resources that we're launching today as we think about very practical tools that we can be using now to really leverage and scale the possibilities of hospital at home, again, for every patient that this care pathway has the opportunity to serve, but also as we think about our ongoing commitment to this work. As we think about what it means to now have a clear patient-centered and very applicable vision for how to do sort of hospital at home at scale, and moving beyond this to think about what are the regulatory frameworks, what are the evaluation frameworks that we're going to need, how do we think about long-term reimbursement strategy. This work lays the foundation for asking those sorts of questions that need to be asked and answered before the current waiver expires, and questions that we are committed to answering at Dime and with our community as we drive forward. So Jake, Abby, thank you so much for welcoming everyone, going through the resources today. To our partners, thank you for your work. And I'm delighted to turn the mic over to my friend and colleague, Grace Cordovano, our patient in residence here at Dime, who's going to lead a tremendous panel discussion that's really going to dive into our success stories to date, the value of these resources, and how we need to keep pushing as a community. Grace, over to you.
Thank you so much, Jen. Just from the patient and care partner and family perspective, I'm so incredibly excited by all of these resources. I can't tell you, this has been years in the making where I now have a resource that I selfishly can now send to every doctor, every patient, every family with a link to just push back and educate and bring awareness to the community on all these barriers and pushbacks that I've heard from, well, how are we going to evaluate? How are we going to measure? What about reimbursement? What about ROI? What about implementation? There's so many barriers. We can't, these resources show that we can, and then some. So thank you to everyone who has been supportive and working tirelessly in this project. It is an absolute honor to be able to now dive into our panel discussion with my esteemed panelists, Gregory Schneider, Julie Heisenbelli, and Lee Fleischer. Can we please have them join on? welcome to my esteemed panelists who are going to steal the show right now. I'm going to turn it over to each of you individually to do a quick introduction, and then we'll dive into questions. Gregory, I'll start with you.
Thank you, Grace. Pleasure to be here, and thank you for involving us. We are honored. My name is Greg Snyder. I'm Vice President of Clinical Strategy and Quality Improvement. On the title slide, it lists Medically Home Group, but as of today, it is Dispatch Health. And so today we publicly announced our merger with Dispatch Health. And so I'm honored to really announce that here with this group. We have led the space of home-based acute care from the perspective of an enabling partner and look forward to really building one of the largest home-based acute care infrastructures in the country. Pleasure to be here, Grace. Thank you.
Fantastic, and congratulations, and thank you for sharing that announcement with us here today. Julie, over to you, please.
Thank you, Grace, and hello everyone. A pleasure to be here also from my side. I lead Connected Care at AWS, representing Amazon Web Services, but also amazing colleagues that contributed to this project. I just wanted to thank and to reiterate how great it was to work into this community. So thanks, Time, for bringing it together. Every day I work with, providers, hospital systems, governments, and this is timely manner and this is much needed. So I'm happy to be part of this and looking forward to the discussion.
Thank you so much, Julie. Lee, over to you.
Yeah, thank you, Grace. And it's a privilege to be here. And congratulations, Dime, and all of your partners on what you created today. I'm currently a professor emeritus at Penn and CEO of Rubrum Advising, but of relevancy, still a practicing anesthesiologist, but of relevancy in July 2020 became the Chief Medical Officer and Director of the Center for Clinical Standards and Quality at the Centers for Medicare and Medicaid Services. And in November 2020, working with the Hospital at Home Users Group, I had 7 days, I still remember them vividly, in which I stood up the hospital at home waiver and have written a lot of the papers out of the CMS data and continue to advise Congress through the Bipartisan Policy Center on hospital at home.
Lee, thank you so much. So on that note, I'm going to start with you. Can you kick us off and say, based on your experience and expertise, what were some of the key considerations that really shaped how the hospital at home program was designed? Could you comment particularly when it came to patient eligibility, provider oversight, or guardrails for quality? And can you also touch on how did those choices really aim to balance flexibility with accountability?
Yeah, thanks so much, Grace. And I think it's important for people to realize what was happening at the time. And, thank you to the people who started this way before I got involved, and Bruce and others, David Levine, that really pioneered it as part of a CMMI demonstration pilot. But in November 2020, I still remember Seema Verma, my boss at the time, who had hired me into the agency, came back from the White House, and Deborah Birx said to her, "We have a crisis in this country and we don't have enough beds. You got anything left?" Literally, that's what she said. And the answer was, we had just heard a presentation on hospital at home, and it said, "How about this program?" And she said, "Okay, you have 7 days to stand it up." So essentially, and you have to remember, I'm an anesthesiologist who oversaw a critical care department for the first 3 months of the pandemic. The question was, it's got to be patient choice. Patients have to feel it's as safe. CMS didn't have a way to pay for this other than saying it's a hospitalization. So there had to be program integrity, which is why it had to start in the hospital, whether the emergency department or in the ward. It had to be considered actually a ward of the hospital. At the time, we didn't even have any markers to say that this patient was in the hospital at home program. We, in fact, asked the patients and got consent from the family, getting Grace to the importance of the entire family experience, to agree. And in the end, we thought it was really important, and all the data that was requested was to make sure this was safe. And the team that I oversaw, which was a number of physicians, nurses, and lawyers, really reviewed every single program. I actually had to individually approve every hospital during my 3 years in the agency. We learned about every major event and sent out alerts to the entire system if we found there were problems. We actually did find a few problems around DME and other things. They were successfully addressed. And in the end, a report came out from Congress that was requested that showed a number of interesting things, which is it was a predominantly more affluent, which is very few duals, which may reflect the state of what's happening in the states and Medicaid, not uniformly accepted, as you've talked about. Patients were very happy, and it was as safe, at least in the way they could match patients. And what it's been difficult in trying to explain to Congress, it's a selected patient population. That's the way hospitals work. We select who goes to the ward. We select who goes to an ICU. We select different decision processes. In talking to Congress, they're still concerned. I mean, there's bipartisan support. They don't think they have enough information to know how to pay for this, whether it should be the full DRG. They actually also pay GME, so costs for medical resident training. And how should this be incorporated into the conditions of participation, which is something we're continuing to work with DIME, and I look forward to working with Jennifer and her team in trying to answer Congress's questions about how do we make this permanent. And they are prepared, from what I'm hearing, to extend it, but not yet to make it permanent, since those questions are not yet answered.
Wow. I mean, I can't thank you enough for all of your deep insights, but most importantly, thank you for all of this work in 7 days. No pressure to get this
It
done.
was an amazing team, including external experts. I cannot thank them. We probably had calls almost every day.
And I just want to point out what stuck out to me. I mean, there was a lot of things, but patients were happy. And when you think about the care that patients receive in care settings, it's not easy always to get a happy assessment. So clearly, a lot of things were done incredibly well and left patients satisfied. And I certainly can see that being an increasing trend as more of this rolls out and deploys. Julie, I'd love to tap you now for some additional perspectives. Now shifting over to the foundational pillars of hospital at home from a tech perspective. How can technology not only enable core capabilities, but also really reduce operational burden, improve the patient experience? How can we help patients feel more connected to their care team and the hospital when they're not there?
Yeah, absolutely. That's a great one. So I remember I read a survey from Accenture. It was a couple of years ago. They interviewed like 12,000 people across 14 countries, and just to understand what's the perception of healthcare. And they found out that it's not one-way transaction anymore, like it used to be, right? Patient did what the doctor, the provider told them. Now it's getting more, and thanks to the accessibility of information that we have, patients already feel more empowered to better understand their health and to discuss it with their doctors, right? So there is a propensity from a patient perspective to leverage more the technology. And this is in all phases of the patient journey, whether this is to have the information, whether they are in the hospital, what happens afterwards. This is a constant acceleration of adopting these tools and these capabilities, right? And what I liked about the resources that we put together is that it leveraged the expertise of different organizations, us being one of them, but also providers and other ecosystem stakeholders to say, okay, this is how we implement it. Your organization might not be meet all of them, but you can leverage, and you need to be aware on how which are the pillars and how we build it, right? And this is fundamental because there are so many things. So when you think of technology and remote patient monitoring or hospital at home, you immediately think of the devices and how they are going to be implemented. But huge, part of it is also how do you actually organize your care navigators, your systems into the hospital? How can you put together the e-prescribing, the post follow-up capabilities? So what are those tools? And into the doc and the resources, and Jake just talked a little bit about that, but we identify how to build the core technology stack. So we identify those pillars that to us, and given the what we have implemented in the past, this has been fundamental for every organization to know, to be aware, so they are successful in their journey. And there are some strong pillars which are foundational, like the integration and interoperability, integration with the EHR, for instance, security, compliance, but also how to build those systems which are, put the patient and the clinician at the centers. Because at the end, when I remember, I will just give another, a couple of numbers, speaking to hospital systems in the US, they said that 50 to 80% of the calls are actually, followed by manual task for the agent that, manages the patient and the access of care, right? Now, technology has evolved and can provide us some support to that, right? Can ease the burden on to reduce the manual task and to actually give back more time on tasks to support the patient, and to have more efficiency into the communication within the hospital as well.
I love this, and I'm honing in on efficiency. One of the most inefficient processes is discharge, routine discharge from standard care, because we let patients go home, and this is where the chaos begins. And what I'm hearing and seeing from our resources is there's no excuse here. This is very meticulously mapped out, and there's been insights and foresight into how to make this work seamlessly. And there's been a lot of technology that is going to be going into a feedback loop to make sure that no balls are dropped. So I really love those perspectives. Thanks, Julie. Greg, I'm going to turn to you and ask you sort of a tough question. In your view, let's get into the crux of it. What makes a hospital at home program really patient-centered? Not theoretically, but how are we executing to make sure that we get this right?
Grace, I appreciate tough questions, so thank you. And I would just say that one of the ways in which hospital at home is truly patient-centric, this may be different from, I think, the way others have viewed this, is the mindset of the clinicians that are involved in the home or virtually. I think, building upon what Lee and Julie have offered, I would say that hospital at home is a field, it is a movement, it is a mindset of clinicians as much as it is a technical and operational infrastructure that allows doctors and nurses and paramedics and EMS professionals, among others, to provide care for patients in their homes. And to your question, Grace, we have applied hospital at home to our unique infrastructure in the United States, but this is really a global phenomenon and an international movement that has been done for decades in other countries. And we are learning from them just as much as we are learning ourselves here. The common thread among other countries and clinicians all over the world as it relates to hospital at home is the mindset of doing the right thing for the patient by treating them in their home. I mentioned earlier that I work with dispatch health as it relates to quality and safety, especially. I'm a clinician as well. And I think when I refer patients in the Mass General Brigham program for home hospital into their homes, I feel like I'm doing the right thing for the patients. I'm able to see them and make sure that clinicians are meeting them where they are, understanding some of their social drivers of health in addition to their medical conditions. And Grace, to your point, really reducing the transitional care gap from hospital to home or hospital to post-acute care. There's an opportunity with hospital at home as the keystone to make a fully home-based care continuum where we're able to seamlessly transition a patient, not just from their acute care in the home, but also to their post-acute care in the home. So those are the things that I think make this truly patient-centric. We're re-centralizing care around the patient and bringing the goods and services to them in a way that's technology-enabled.
So many great points. I really love your perspective on describing this as a movement and really a continuum of care. And when we think about the fragmentation that's happening in our care, what a beautiful opportunity to do things better. But I'm also, what's crystallizing for me is that we're also building conduits and pathways to trust, multi-stakeholder trust. We all have to sort of trust each other to make sure that this is going to flow seamlessly. And resources like this and the collaboration of you all and the work that you're doing and our partners really helps to build that trust and that momentum to make this movement successful. Lee, I'm going to jump to you, and I really would love to hear now as we think about expansion of hospital at home programs. One of the things that, of course, is going to come up is how do we prevent misuse and overutilization? So I'd like to ask, for your perspective, how should we be thinking about guardrails? What mechanisms should be in place that are most important to ensure that the model remains high value and patient-centered?
Well, it's interesting that you start with trust, and trust has become such an important part of so many aspects of healthcare. It's interesting. I'm involved in a World Economic Forum group that's about brain-computer interfaces, and the number one thing we may have heard there was an implant just a few days ago was, do we trust that our brain waves are not, our thoughts are not going to be abused. So trust in this center is so important. When we look at two programs, and you probably hear the administration talking about fraud, waste, and abuse, they're actually different things. Waste, to my mind, is you don't need the care. Fraud is actually saying that you have care that didn't get delivered. So I think we need to take those in different ways. So in the fraud, and they worry about home health, is this home health, but they're paying a hospital DRG? So there's really concern that these patients wouldn't be admitted, that they wouldn't need a 2 midnight stay, so that we need to make sure that they really do believe that this is a patient who otherwise would have had that hospital admission. So that is why we designed it originally to start in the hospital, that there's documentation. We actually required the CEO, CMO, or Chief Nursing Officer to sign off on the waiver, that they took responsibility. As you may know, Medicare requires 2 midnights. And if it's only 1 midnight, you actually have to justify that quite strongly. So that's, I think, one of the things, and why I think it's important to keep this under a hospital, not a freestanding facility, because they're regulated under the conditions of participation. And I would be worried about that issue. The other is to really maintain that key safety issues for the patients. I think how it's been done, and Greg just so nicely outlined, as well as Julie, as far as using remote monitoring. We said 30 minutes. I think with all the technological advances, what that means can probably change, be it inner city Boston versus how do we get to the rural individuals by using predictive analytics and having this a little further from the hospital setting. Because as you said, Grace, the real advantage is keeping people in the home for the continuum. So those are the trust that the government, but also the patients need to feel.
Thank you so much for pointing out all those things that need to be delineated and how we can address some of them. Now, it wouldn't be a conversation if we didn't talk about AI. So now, Julie, I'm going to turn to you. Let's talk about how does AI and machine learning fit into this tech stack for hospital at home success? And I'm going to selfishly start with particularly around patient communication tools.
Yeah, and that's a perfect segue after what Lee just said around data analytics and how can we leverage the technology and tools, machine learning, AI, toward an impact and an outcome, which is to make the patient safer at home, but also, to build the trust. I really love that angle, Lee. So thanks you for outlining that. Now, I think what have emerged with the implementation of AI, machine learning, and generative AI in the last couple of years, is that the way that we communicate has profoundly changed and can be more supported by that on access to care, post follow-ups, capabilities on how patient can have all the information they need, whether they are at home or prior to the visit, so post visit the doctor or prior to it. They have all the information in place to manage their health. One of the problems that has been in the past, in my experience, always for remote patient monitoring, so especially for chronic conditions, you have a dropout after 30 days because patient, they kind of have to deal with all the conditions, but you have also to support them to be engaged and to continuously share, the value of what is bringing the impact on their health. Now, these tools and capabilities like machine learning AI can leverage the data and proactively communicate with the patient to say, okay, this is how well you have done in the last week. This is what you need to do according to your clinical protocol that was shared by your clinician, right? So just not just that, we have seen that is impacting on reducing the number of readmissions, for instance, right? But there is also an angle of the experience that the patient have, right? One of the examples that is cited into the resources, what we implemented with Tufts Medicine, they were all on AWS, so they've been on a transformative journey, but one peculiar, so they leveraged omni-channel capabilities with AI embedded into it to allow patients that are not English native speakers to write into their language. And on the other side, they had, the translation in real time, and the provider could, see the messages in English and answer to that. I think that is a, simple implementation, but can be profound in how patient then perceive the it shortened the distance with the providers, and it empowers the experience as well.
I so can appreciate that. I see this in my regular patient advocacy work day to day on how AI is now transcending language barriers and enabling communication, but also it can be adjusted and trained to be more compassionate, more human, more culturally sensitive in the responses and the communications. So I think that there's definitely a strategic value to this to improve lines of communication, and also collecting, I think, richer data, because it's not a rushed encounter. It's in the comfort of someone's home, and they may be more apt to share in a different manner than in a stressful, rushed appointment that may be a scale of 5 to 9 minutes.
Yeah.
I'm going to... Oh, go ahead.
Oh, no, sorry, just another one. Another thing that is important that machine learning and AI and data, and actually the capability of viewing the data of more patients and understanding who is actually, need an immediate, communication or engagement with the clinicians, and who is doing all right. So that capability of analyzing massive amounts of data is also another opportunity to reduce the operational burden from the clinician perspective and from the provider perspective as well.
Really great points. Thanks for making a note of that. Greg, I'm going to turn to you. And unfortunately, it seems like you're in my line of fire of follow-up questions. So as we think about where this conversation is going, my next natural question is, we need to think about equity and access in the context of this model. What design decisions would help ensure that this model doesn't really widen gaps and actually improves care and access for all patients?
Yeah, thank you. And Grace, as I mentioned, I really appreciate the tough questions. We're confronted with tough questions a lot in this field. Let me also just build on the question to Julie around, AI ML. We've deployed this tool or similar tools in natural language processing and other forms of artificial intelligence to problems like patient identification at the point of admission, or clinical deterioration, of patients in the home and really predicting that. We've also done it for geolocation and route optimization for supply chain management. But I think of AI and other forms of technology enablement that is software enabled as tools among many that we're deploying to build out this sort of technology stack for acute care infrastructure. All of those tools, Grace, to your question, need to have equitable principles of design in mind for patients in the home, for example, that have various forms of hearing, visual, mobility impairments, where we have to have an equitable lens on the types of hardware and software that we deploy into the home in order to expand access to this model. Earlier, Lee mentioned that in the CMS report, there were some findings that suggested that patients in this model under the fee-for-service Medicare and Medicaid and duals waiver were predominantly white, predominantly centered in urban locations, and very few low-income subsidy patients. And so those are the types of problems that we can use technology to help us solve. But Grace, to your question, the solution to that problem comes squarely with leadership and the values of the clinician, operational, and technology leaders that are solving those problems. And so one space that we talk about a lot in hospital at home is addressing social drivers of health and socioeconomic vulnerability in the home. And so I've appreciated the DIME endeavor to help us measure that more so that we can manage it more and deploy some of those technologies and services that help us manage to that problem. Another way in which I feel that access and equity needs to be addressed as we move this movement forward is through the provision of rural hospital at home and addressing some of the acute care access gaps that our rural population faces in this country. And so those are design principles where there's currently underway trial work and operational work and services work, both in government settings and academic settings and industry settings to help solve those problems to bring this model to more patients.
Thank you so much. I'm being mindful of time. I would love to keep this conversation going, but I want to squeeze out every last bit of wisdom I can. So let's do a rapid fire question to wrap from each of your perspectives in 30 seconds, if possible. Why do you believe hospital at home should remain a core part of healthcare delivery moving forward? I'm going to kick this off to you, Lee, and then we'll go to Julie and Greg to close us out.
It allows a continuum of care for the right selected patients by starting at the home and continuing them with the safety net of the hospital.
Amazing. Julie?
I will go back to what Lee says earlier. So it empowers the trust between the patient and the provider, and it's really, bring those scalability to help more people with less resources.
Wonderful. Greg, close us out.
Thank you, Grace. And I would say that that's the right thing to do for our patients. I would challenge the fact that facility-based hospital care is the right thing to do for all of our patients. And I think we have the opportunity in hospital at home to do it better in patients' homes. And that's a call to action to all of our clinical, operational, and technical leaders out there that we can provide acute care in a way that is truly better in the home.
Mm-hmm. I mean, this was fantastic. If I had a mic, I would have Greg close us out and drop the mic. I couldn't have asked for a better conversation, and we finished on time. So thank you so much to all of you for the amazing insights, the richness of the work that you're doing that has helped fuel and bring this model to more patients, but also in partnership with DIME and in release of these resources and with all of our partners from the patient and care partner and family perspective. Thank you all. And now I'm going to turn it over to Ben.
Thank you so much, Grace. And thank you all again for joining us today. I think it's been an inspiring discussion, and I want to take a moment to acknowledge the tremendous effort that brought us to this point, and which would not have been possible without the collective know-how and expertise of all of our partners. We heard from a few of them, but there's many more. To kind of briefly recap what came up in the discussion, or at least what came up in the discussion for me, is that we heard about the resources themselves, of course. Jake walked us through that. I encourage everyone to browse through those because they were really designed to be valuable to both people who are entirely new to hospital at home, but definitely also experts. The insights into the origins from hospital at home from Lee and others on the panel were definitely very interesting. to hear on how this all came together, how we need to think about organizing these kind of programs, how we need to think about paying for these programs. There were plenty of insights into considerations on how to build patient and clinician-centric programs that are available to all. Insights in how to make hospital at home part of the care continuing and generate trust with everybody who touches it and who would be affected by it. And then last but not least, AI as an important tool to generate some of the, let's say, connective tissue for building these programs. And I think we're all in agreement that it would be easy to think of these kind of programs, the hospital at home programs, as bespoke clinical workflows that are optimized for the home environment versus a traditional brick and mortar environment. And I think it was clear from the panel that obviously that is true, but it is so much more than that, right? And Jen also made comments along the same lines. It's about bringing high quality care to the patient as opposed to bringing the patient to the hospital when that can be avoided, right? Where it is appropriate, of course. It's about integrating these workflows into existing clinical workflows to not to replace them, but to extend them, to expand them, to make them better, right? Because we create the ability to meet people where they are and tailor care to their needs and circumstances. It's about acknowledging that connected health technologies are key to making this all possible, not for the sake of using gadgets, not for the sake of using AI, but to ensure we build safe and effective programs that raise the bar on quality in healthcare. And I think if we take all of that together, that today really is a milestone for Dime and all of our partners who worked hard on these resources, but it's also the beginning of the connected health collaborative community. And I think because it's the beginning, it's also a call to action, right? Like these resources, they provide a strong foundation, but the real impact comes from now implementing them, iterating on them, continuously improving them. So the work ahead is clear. We need to scale these programs. We need to navigate the regulatory and policy requirements. We need to refine best practices, ensure equitable access, all of those things, everything that came up in the panel, everything that's discussed in the resources. And it is going to be challenging, right? We acknowledge all that, but together, I strongly believe that we are more than capable. And to kind of try and close this out, I think we really have an opportunity here to transform the way care is delivered at scale, right? That piece is really important, the scale component of it, to make hospital at home not just that add-on or an alternative, but a tried and true method to deliver high quality care for those who need it most. And my personal hope, and I think that hope is shared by everyone at Dime, definitely, and everyone here on the webinar, is that the connected health collaborative community that has come together around hospital at home will carry this momentum forward, right? Acutely, and I think also echoing what Jen mentioned at some point, we need to focus on addressing regulatory uncertainty for hospital at home, and that is exactly what we're planning to focus on next. And in addition to that, we have Aging in Place of Choice initiative that's going to come up that will build on the foundation of hospital at home to extend it to care innovation that addresses the needs of seniors, regardless of the acuity of the situation, right? And I think that echoes some of the comments also in the panel about this creating this continuum of care. So let me round it out by saying thank you again to everyone who worked so hard on making sure we could release these important resources to the world today. And please consider this a very warm invitation from Dime to let's get to work on tackling the challenges that are ahead. And with that, I'll hand it back to you, Abby.
Great. Thank you, Ben. What a great discussion. Thank you, Grace, for moderating, and Julie, Greg, and Lee for sharing your insights with us today. It's been incredibly meaningful to share the launch of this work with so many of you, leaders who are not only shaping the future of hospital at home, but also championing a broader movement toward patient-centered, technology-enabled care. What we've built together through this project is more than just a set of tools, it's a foundation for scaling hospital at home in ways that are operationally sound, clinically safe, and truly sustainable. And it's also the foundation for what comes next. As the Connected Health Collaborative community continues to grow, we're excited to carry this momentum forward into our next project that Ben just mentioned, Aging in Place of Choice. With over 100 million older adults in the United States, 37 million care partners, and thousands of care teams working to support them, we have a critical opportunity and responsibility to build an ecosystem that enables people to age with dignity, safety, and support in the place they choose to call home. This next chapter will focus on building scalable, technology-enabled solutions that empower individuals and families, while ensuring care teams are equipped to meet the moment with integrated, person-centered approaches. We're thrilled to continue this journey with many of you, and we welcome others to join us as we take on this next challenge together. On behalf of the CHCC team, thank you again for being part of today's launch and for all the work you do to make healthcare better for everyone. Thank you for joining, and we'll see you next time.